guys, in this lesson we are going to be going over the diagnosis called bronchiolitis. Now, bronchiolitis is a very common reason for admission in the pediatric world, and it's really known as being a winter or early spring diagnosis. So those are the most common times that we see it in the hospital. And it's actually caused by a virus called the Respiratory Syncytial virus, or what I'm going to refer to it from now on is RSV. Now, babies who have RSV can deteriorate very, very quickly. So your knowledge about this diagnosis and your ability to know when they're tanking really and truly can save their lives. So let's get started going over this content. All right, so bronchiolitis is an infection of the lower airway, and you've also got inflammation in those lower airways. And this is especially in the bronchioles, and I'll show you more about that in just a second. Now, the major characteristic of this illness that I want you to remember is that there is a lot of thick mucus being produced. And this mucus leads to obstruction in both the upper airways and the lower airways. So for the upper airways, you're actually getting blocked noses. And for babies who actually prefer to breathe out of their noses, this leads to a lot of difficulty with feeding, which ultimately can lead to dehydration, which really, really complicates the illness for these babies. In the lower airways, or in the bronchioles, what you're getting is those smaller airways are blocked with mucus, and this ultimately affects gas exchange, which results in the hypoxia that we so often see in these babies. So let's just pause really quickly to remember a little bit about the lungs. So the bronchioles are these very small little airways that extend off the bronchi and the bronchus. And at the end of all of those bronchioles are millions and millions and millions of teeny tiny little alveoli. And the alveoli are often referred to as tiny air sacs. And this is actually where all of the gas exchange is happening. So when there's mucus blocking the way of all of that happening, you can get really compromised air exchange. In keeping with what we just talked about, the first thing you're going to notice in your nursing assessment is going to be copious amounts of nasal secretions. And what this looks like in real life is babies who have a lot of snot and boogers. And so that's going to be the first thing that you probably notice. Now, these babies are also probably going to have a cough and a fever. And for the first few days of the illness, that might be all that they have. It just kind of looks like a regular cold with upper respiratory symptoms. Now, over the next couple of days, usually this illness peaks or is at its worst between 4 to 6 days. And at this point, you can start to see changes or increased effort in their work of breathing. And the main things that we're looking for there are things like nasal flaring and retractions. Both of these are signs that the baby is having to work extra hard to move air in and out of their body. So the nasal flaring is just that baby trying to increase the size of their airway, and retractions are a sign that they are having to use all of these extra muscles to actually move that air. And you can see in the photo here, so they're having to use all of those extra muscles to get that chest wall to move to help them to breathe. And then they're also going to start breathing faster as well to compensate for those difficulties. So these two symptoms, or these things that we just talked about, are so important because when you pick up on the fact that a baby is having to work really hard to breathe, you can contact the provider or respiratory therapist and get that baby some help so that they don't get overtired and crash. Now remember, increased work of breathing trumps a normal oxygen saturation. So a baby may have a normal oxygen saturation of 96%, but if you have assessed them and you notice severe retractions and nasal flaring and they look tired, that is when you need to step in. Don't wait for those oxygen saturations to drop. So when you auscultate this baby's chest, you are going to hear a lot of different noises. All of that mucus is causing wheezing and crackles, and then there are also going to be a lot of upper airway noises that you have to try to listen through as well. When you check their oxygen saturations, it's very likely that they could be hypoxic, so it's very important to make sure you cover that in your assessment. And last but not least, it's super important to pay attention to their feeding. It's very common for these babies to have difficulty with feeds, and this could either be from the fact that they're tired or it could be that they have the blocked nose, which prevents them from being able to feed. So make sure you keep an eye out for signs of dehydration, because that's a really common cause of admission for babies with bronchiolitis. Therapeutic management of bronchiolitis is pretty much just supportive. So the major things that we're going to be doing are providing oxygen and fluids. Now, the oxygen may be given via nasal cannula, or sometimes we actually have to use something that's called high flow oxygen. And what happens with high flow oxygen is that we're actually giving some positive pressure to the lungs, and this helps keep those tiny airways, the alveoli and the bronchioles that we talked about, it helps keep those open, and that helps reduce some of that work of breathing that those babies are having to do. And then remember, I said dehydration is a very common cause of admission, so we've got to make sure that these kids are getting fluids, and that can be done either through an IV or through an NG tube. Now, ideally, we like for babies to keep feeding as they normally would for as long as possible. But if they are tired and lethargic, or they're breathing really fast, we don't want to risk them aspirating. So we need to give them fluids, again, through the IV or NG. It's really important to remember that bronchiolitis is usually caused by a virus, which means it's not going to respond to antibiotics, so these kids are not going to be given them. And there are a couple of other treatments like chest physiotherapy, bronchodilators, and antivirals that are actually considered to be a little bit controversial. And the reason for this is just because that there's some different evidence that shows that some of these are not as effective. So let's just expand on this topic of bronchodilators a bit, because you may actually see them prescribed in clinical practice, even though the research shows that for the most part, they're not necessarily effective. Now, the reason that they aren't considered to be effective is because the wheeze that you get with bronchiolitis is primarily caused by the clogging with the mucus. Bronchodilators are usually effective when the wheeze is caused by inflammation and narrowing in the airway, which we often call bronchospasms, and that's what you usually see in patients with asthma or COPD. So most of the time, bronchodilators, we wouldn't think they would work when the wheeze is caused by the mucus. But sometimes in more complex cases, like maybe a baby has an underlying disorder, or maybe they've had multiple episodes of a wheeze, in these instances, a bronchodilator may be described as a trial to see if it's helpful. Now, if this is the case, it's very, very important that this patient is assessed for its effectiveness immediately following the treatment with the bronchodilator. If it did not have an effect on the wheeze, then it should be discontinued immediately because of the side effects like tachycardia and hyperkalemia. Now, I know that's a lot of information, but the key thing to remember is that we are giving supportive treatment like O2 and fluids, but sometimes you may see some of these other things in your more complex patients. So in addition to the oxygen and fluids that we just talked about, there are a few other really important nursing interventions that are really going to help these babies. So the first thing is we have to keep a super close eye on their oxygen levels. So they need to be on a continuous pulse ox monitor. And these babies are also really prone to apneic episodes, especially if they were born prematurely. So there may also be a need for an apnea bradycardia monitor. Another really important and very simple thing to do for these babies is to make sure the head of bed or the head of the crib is elevated. And this is really going to help them manage those secretions. And remember, these babies have big heads, so sometimes it's helpful to put a rolled up towel under their shoulders. And this actually helps keep their heads from falling forward and occluding their airway. Probably the most important thing we can do is regular nasal suctioning. And this is, again, because they have so much secretions. And I'm not talking about deep suctioning here. We're just going to use a regular bulb syringe or the neo sucker that's attached to the bedside suction. And the goal is just to help keep that nose clear. And this not only helps them breathe, but it also helps them feed. And last but not least, RSV is spread through droplet and contact. So when you go into the room, you're going to need a gown, gloves, and a mask. Your priority nursing concepts for a pediatric patient who has bronchiolitis are oxygenation, gas exchange, and infection control. Okay, guys, let's go over our key points for this lesson on bronchiolitis. So remember, bronchiolitis is an infection in the lower respiratory tract, and it's specifically in those bronchioles that we looked at early on. Remember, it's mostly going to occur in winter and early spring, and it's usually caused by a virus called RSV or respiratory syncytial virus. The most important characteristic of this illness to remember is that there's a lot of mucus production, which causes obstruction in the lower airways. There's also going to be a lot of nasal secretions, which could lead to the baby having difficulty feeding and ultimately dehydration. Our treatment is mostly focused on giving oxygen and fluids, so that may be either through a nasal cannula or high flow oxygen, and then you can be giving fluids through IV or an NG tube. Now, always keep in mind that these babies have to be monitored very, very closely. They can tire out and deteriorate so quickly. I've seen it happen over and over. So always remember, increased work of breathing trumps a normal oxygen saturation. A baby who has retractions, nasal flaring, and is tachypnic needs intervention. Don't wait for those sats to drop. RSV is spread by droplet, so our infection control is very important. So we're going to have droplet and contact precautions in place. So make sure you've got the gown, gloves, and mask on when you're going in to take care of those little ones. All right, you guys, that's it for our lesson on how to take care of a patient with bronchiolitis. Make sure you check out all the resources that we have attached to this lesson. We have links to 2 really awesome videos about this diagnosis. One of them is an interview with a parent about the experience their child had, which is really insightful and really helps you understand what it's like for them. And the other is a patient education video that goes over all the different things that you should be able to talk to families about when it comes to this diagnosis. Now, go out and be your very best self today, guys, and happy nursing.